All right, guys. I listened to the review that our professor sent out, so I'm just going to kind of follow through what she talked about, but also add in my little things that help me remember all of this stuff. So the first thing she says that we need to know, which we should all know this by now, is the ADPI. But it's not just going to be the definition of those. It's going to be scenarios and identifying what part of ADPI it is. So probably say nurse did a head to toe assessment, or the nurse got vital signs. So that would be your assessment for A. And then she might ask, what is the problem with this patient? Are they having shortness of breath or issues with perfusion? That would be your diagnosis. And then your planning and interventions. It's kind of self-explanatory. What are you going to do to fix those problems? And then the intervention is actually putting those plans into place. So like raising the head of the bed or applying oxygen would be your intervention. And then your evaluation is going back and seeing and evaluating if it helped. Let's see. Also with the plan of care, remembering that we cannot initiate the plan of care, we just contribute to it. So just remember, RNs are going to be the ones that initiate the plan of care, but we can help contribute to it. Informed consent is going to be on this exam. Just remembering mainly we're just there to witness the signature. The physician must tell them about the procedure. They have to tell them about any risks with the procedure, any other alternate treatments that they could do, and make sure that they understand it. If we go in the room and they're still confused about it, we have to go back out and get the doctor to re-explain it. We can't explain it at all. We just can witness the signature, and that all of our patients have the right to refuse this. They don't have to sign the informed consent. So the nurse patient safety goals, the national patient safety goals. Once again, we need to make sure we know those. Don't get tripped up on the IDing patients because they threw that in there, the name and room number. That is not a way that we can identify. It needs to be name and date of birth. The other one is improve staff communication. So like if they get really important test results, we need to get that to the right person. Using medication safely, making sure that we're reading medicine labels, or taking care with patients that are taking meds to thin their blood, that type of thing. Using alarms safely, even on medical equipment. Prevent infection. So good hand hygiene would be an example of that. Identifying patient safety risks. The example they give on our handout is reducing the risk for suicide. Improving healthcare equity, or quality, and patient safety is priority. And then preventing mistakes in surgery. So when they do that stop and pause, timeout, that would be an example. She said also that once again, sentinel event is going to be on the exam. So people are still getting a little confused with it. So just remember there's other things like a near miss, which is they go to mark the leg for amputation and they mark the wrong leg, but they catch it before they cut the leg off. That's just a near miss. That's not a sentinel event. Or an adverse event would be gave a patient the wrong med and they get a rash, just little allergic reaction. That's not major, it's not good, but it's not like threatening to life. The sentinel event is severe. So either death occurs or severe infection where they end up in the ICU, or they lose an arm, amputation due to what happened. So just remember Sentinel is like severe. It's not like a minor rash. Once again, malpractice is on this exam. So just remember the 4 things you need for it to be considered malpractice is the duty to patient. So you took care of them. The patient was injured, so there was injury. A breach of duty, which is basically just saying you didn't do something and it led to them getting hurt. And then the cause effect of that. So pretty much the breach of duty is you don't do this thing. And then the cause effect is that you didn't do something led to injury, I should say. So say they're a low bed with mats because they're fall risk and you forget to put that bed low. They get up and assisted, they fall and break their leg. That would be considered malpractice because 1, you took care of the patient. 2, they received or got an injury. They broke their leg. The breach of duty was you did not put that bed down and the mats there for their safety. And the cause effect of that, of you doing that and forgetting to do that, and they broke their leg, can lead to malpractice. I'm sending you guys after I record this the paper and handout we got that has the scope of practice do's and don'ts. So you want to make sure you guys refresh yourselves on all of those. She said that there were still some people getting kind of mixed up on that. Remember, if they are under 18 years old, we really can't do anything except change the dressing. We can't start an IV or anything like that. So just remember, if they're younger than 18, if it says anything besides change the dressing, that's nothing we can do. Above 18 years old, we can start an IV, but it has to be antecubital and lower. So elbow and below. We can't do an IV in the upper arm or anywhere else. And it has to be 3 inches or less. In regards to central lines, we can't remove those. We can't change connectors. We can change the dressing on it. We can hang a lot of those fluids, most all of them, except with the vitamins and electrolytes that are added to it. We can't hang that first bag. We can only hang the second bag. We also can't hang blood. We can't hang heparin. We can't hang TPN. And we cannot give an IV push. Another thing that we can give is those IV piggybacks, antibiotics. So it'll be initialed IV PB for IV piggyback. And then your IV push might be in parentheses as IVP. So just remember not to get those 2 confused. We, as an LPN, cannot teach at a school or anywhere like that. We can educate our patients on certain things, but we can't teach. Also, we can educate our UAPs on like things like bed making, just something simple like that. She said that we need to know the 3 different IV antiseptics. So just remember it's the alcohol 70%, the fluoxetine and iodine. IV fluids can be used for either maintenance or replacement. You need to know the difference between those. So your maintenance is like your normal intake for the day. So what you would normally drink. So if you're NPO, they're going to give you fluids that you would normally drink through that IV since you're NPO, usually for surgery or something like that. Replacement IV would be you're replacing lost fluids. So they're having extreme vomiting or diarrhea, or they've lost a lot of blood. You're gonna do the replacement IV. A big thing, I know you guys are struggling with, which I'm gonna send my sheets that I made little sheets on it, is the different types of solutions. I know they're a pain in the ass, but pretty much it's memorization. And then I did throw a few hints on the paper. It's kind of, you know, your isotonics, you should be able to weed them out to determine if they're hypotonic or hypertonic. Just remember isotonic, your normal saline. So 0.9%, the NaCl or NS, which is the same thing. And then you have your dextrose 5 in water, your lactated ringer, dextrose 5 with a 0.225% normal saline, and 5% albumin. I don't think albumin is going to be on this exam. We haven't learned about that yet, and I doubt they're going to throw that in there. So your main ones are the first three. So your normal saline, which is the 0.9, your D5W, dextrose 5 in water, and the lactated ringer. Just remember those. And then going to hypotonic, remember she said anything less than a 0.9. That's just in regards to that normal saline. So the 0.45% or the 0.225% and the 0.3%, just normal saline. That's all that's in that. And then your dextrose is D2.5 in water. So a way to remember those dextrose ones is those double by 2. If you look at it going from hypotonic to isotonic to hypertonic, that dextrose doubles each time. So hypotonic, the lowest one is the D2.5 in water. To make it isotonic, it doubles to dextrose 5 in water. And then to make it hypertonic, it's dextrose 10 in water. So just remember with the dextrose, it just doubles. The lactated ringer alone is isotonic. If you add anything to it, like dextrose, it becomes hypertonic. So you're adding something to it or making it more concentrated. So it's a hypertonic solution. And then your normal saline, if you add dextrose to it, you're adding to that normal saline, it makes it hypertonic because you're making it more concentrated. Just try to think about it that way. Your hypertonic solutions, in addition to those, are your blood, your packed red blood cells, the TPN, and then 25% albumin, which once again, I don't think albumin is going to be on there because we literally haven't talked about it yet. Fun fact, I don't know if this helps anybody. I'll send it on my little hint sheet. Any normal saline concentration is either going to be in fractions or decimals, and it's in relation to the 0.9. So a half normal saline of normal saline is going to be 0.45 because half of 0.9 is 0.45. 1/3 is the 0.3 and half is the 0.225, which I've realized I forgot the 5 in there. If that doesn't make sense, just let me know. Try to explain it better. So the uses. So the big part is getting your solutions straight on whether they're isotonic, hypotonic, hypertonic. Then you're going to have to figure out what's going on with the patient to decide which solution you're going to give. And I guarantee it's going to be like the quiz. They're going to be solutions. They're not going to say isotonic. It's not going to say hypertonic. It's going to be, which solution are you going to give? Is it going to be 0.9 normal saline? Or is it going to be dextrose 10 and water? So really get those down. So your lactated ringer is mainly good for burns. It can be used in surgery and with OB, but your biggest thing that they're probably going to ask, you have a patient with burns, you're going to give them lactated ringers. Just remember that. With any kind of trauma or like fluid loss where you really quickly need to give them fluids, it's going to be your isotonic solutions. But also remember with those isotonic solutions, you do not want to give those to patients who are at risk for not obesity, but like congestive heart failure, heart fluid around the lungs or anything like that, because that's just going to cause more of an issue and give them more water in their lungs, making it harder for them to breathe and for their heart to work. For your hypotonic, let's see, which way do I want to go with this? Oh, also for your normal saline, remember that it's compatible with most everything. That's normally what they're going to give with blood as well, is the normal saline. And then with your lactated ringers or anything with dextrose, you don't want to give that to somebody who's having high blood sugars, because dextrose is literally sugar. And remember that those dextrose ones break down protein. I have notes all over the place, so I'm trying to make sure I hit on everything and all the notes I took both times for the quiz and for this freaking exam. Your hypotonic. So remember, it's taking fluid from the vascular into the cell swells. So hypo, like a hippo, think a fat hippo swelling big. Your cells are going to swell. So with these ones, you do not want to give them to anybody with ICP, because this solution is going to just swell them even worse and make their condition even worse. And then also remember with hypotonic solutions, it brings down your blood pressure. So hypo and hypo. Hypotension, hypotonic solution. Hypertonic is going to take the fluid from your cells into the vascular system, and your cells are going to shrink. So all this water or fluid is going into your veins and your vessels, causing your blood pressure to raise, causing fluid overload. I know it doesn't make sense, but it is good for ICP, because those cells in the tissue of your brain, it's taking them from those cells into your like vascular system. So it does help your ICP get better. But it's not good for CHF or renal failure, because they can't take that extra fluid. I know it's very confusing. Just remember, hypertonic solutions causes hypertension. So at least those go together, hypo and hyper and hyper. Let me see if there's anything else I can help you guys with in that part, because I know that's really confusing. There's notes in your green book in the workbook, starting on page 17, 18, and 19 that I referred to for our quiz, and it kind of helped me. So I'll go over that again, just because I know these solutions are a pain in the ass. So once again, your isotonic, the danger is circulatory overload, because the fluids stay where they're infused in that intravascular space. and they don't cause the fluids to shift into the other compartments. So it's just building up in those places. So you really got to be careful with it, especially like CHF or your kidney failure, because those kidneys, if they're not working to get that water out, it's just gonna build up and build up. Hypotonic, the biggest caution with that is not giving it to patients with low blood pressure, because remember, hypotonic is going to cause hypotension. So if they're already low, it's going to really take their blood pressure really low to a dangerous state. The caution for hypertonic. The hypertonic solutions, remember, are irritating to the vein walls and may cause hypertonic circulatory overload. So it's going to cause that blood pressure to raise. So if they already have high blood pressure, you definitely don't want to give them hypertonic solution. And these are also contraindicated with cardiac or renal diseases because it increases the risk for heart failure or pulmonary edema. Hypertonic solutions are always going to be infused slowly to prevent circulatory overload, and also due to the fact that they're so irritating to the veins. So just remember, hypotonic, hypo swells the cells. Use with caution with your ICP, intracranial pressure, and if your blood pressure is low or your blood volume is low, because it causes that hypotension. Your isotonic, the biggest things you want to remember, lactated ringers are used for burns. Your normal salines for trauma. No fluid shifting. Hypertonic shrinks the cells. Use caution for your congestive heart failure, your renal failure, and your fluid volume excess. It causes hypertension. So those are the big main hints I can give you guys on those. And I feel like that's mainly what the questions are going to be asking in regards to those solutions. So just kind of remember those key points, and I think you guys will be okay. Also on this exam, she's going to have questions on the differences in signs and symptoms for your fluid volume deficit versus fluid volume excess. So I'm going to kind of go through them in each kind of category. So your fluid volume deficit. So you're going to be dehydrated. For both, remember, it's tachycardia. So don't worry about tachycardia. It's going to be in both. So you're going to have a really fast heart rate, whether it's the deficit or excess. Another one for fluid volume deficit is you're going to have low blood pressure. So just remember, the deficit means it's going to be low blood pressure. For fluid volume excess, it's going to be high blood pressure. Just remember, if you have a lot of fluid, it's going to be high blood pressure. Just think of all that water pounding through your veins, making your blood pressure go high, which brings me to pulse. So your fluid volume deficit is going to be a weak, thready pulse because there's not really much liquid in there because you're so dehydrated. So it's a really weak pulse. But in your fluid volume excess, there's so much fluid in there. It's a bounding pulse. So it's pounding. You can feel their pulse really strong. Fluid volume deficit, you're also going to have those dry mucous membranes. Whereas in the fluid volume excess, you're going to have that edema. Fluid volume deficit, skin tinting. It's not going to go back to its place very fast. It's going to slowly go back because there's not a lot of fluid in there. And then your fluid volume excess, you're also going to hear crackles in the lungs. You're going to have them probably be short of breath. They might be having a cough. Their pulse ox is going to be low. And then they're going to have some jugular vein distension going on. Electrolytes. You know you guys love them. The main ones I think that are going to be on there is signs and symptoms of low calcium. So remember, the most major one is those laryngeal spasms because you have a really high risk of having airway blockage. So that's like the number one you want to remember. And then the ones we learned like last term. So your positive Trousseau and Trovesque sign. They're gonna have tingling of their fingers and lips. And then they are also at risk for seizures. So all of that is low calcium. And then there might be a question thrown in there regards to seizures. So it might be you have a patient and they might give us values of a low calcium level. And what are you going to do? So it might be one of those safety things. You might want to have pads on the rails, have the bed lowered, turn them on their side if they begin to have a seizure, those types of things. Another thing that can cause seizures is low sodium. And I think that was the main things with the seizures. She kind of gave a hint if you have anything that's high, especially like potassium, because she said you don't really see high potassium a lot, but mainly if you have high potassium or sodium or calcium, it's normally a big cause is kidney failure, which makes sense. Kidneys are the big filter that get everything out of our body. So if the kidneys aren't working and we're not peeing this crap out, they're gonna just get higher and higher. As usual, high potassium or low potassium can give you heart dysrhythmias. So you want to make sure that we're monitoring them, putting them on a heart monitor. If they're low, doctor's probably gonna make an order to give more potassium. Never give IV push potassium, which we can't even do that anyway, but anybody should never do that. It can cause heart failure. If they have high potassium, I'm gonna probably murder this name. Kayexalide, that medication that we give that binds the potassium and they end up pooping it out. And then she went into the different antibiotics that we need to know. So the meds are vancomycin, which is the strong antibiotic, can be used to treat like C. diff. Some side effects is the red man syndrome, and then ototoxicity and nephrotoxicity. So just remember with vancomycin, they could cause like the hearing loss and the kidney dysfunction. So you're gonna want to look for like low urine output and high BUN and creatinine levels and checking that peak and trough. A way to see if vancomycin is working is their white blood count is going to go down and their diarrhea is going to stop or at least slow down, I would hope. Another medicine that we will have on this exam is Flagyl, which is antifungal. Remember, it's not for viruses, it's not for bacterial infections. Flagyl is antifungal, so FNF. It can cause thrombocytopenia, which is the low platelet count. It can be given IV or PO. Obviously, your side effects, nausea, vomiting, diarrhea. I don't think there was like a major one. I don't remember one. If you guys remember, let me know. Another one is Cipro and the Levaquin. The biggest thing with this one, sign and symptom wise, they both can cause tendon rupture. So if they start complaining about ankle pain, you need to take that seriously. It could be leading up to a tendon rupture. And also the big thing with Cipro in particular is a prolonged QT interval and the EKG, I can't talk. It's a heart rhythm issue and it can cause a dysrhythmia in the heart. So you definitely, if they already have heart issues, you don't want them using the Cipro because it can make it even worse. And then Augmentin. It's two different meds. It's amoxicillin and clavidin. I don't know if I said that right. It's only given PO, lower white blood count, and it lowers the red blood count. So just keep that in mind. And then obviously the lovely ABGs. I'm gonna need to know those. Remember your Rome. That's gonna help you so much. So remember your levels, which I think we all have those memorized now. And then knowing some of the causes. So metabolic alkalosis can be caused by like the loss of stomach acid. So you're vomiting or NG suctioning because you're taking all that acid out. It's making it alkalosis in there. Metabolic acidosis causes. We know this one really well. Comes out your ass. It's metabolic acidosis. So diarrhea or your diabetic keto acids. Respiratory. So respiratory alkalosis. So you're breathing a lot. You're getting all of that acid out. You're breathing too much. So you're anxious. You're hyperventilating. So it's causing respiratory alkalosis. Respiratory acidosis means you're not breathing enough because you're not getting enough acid out. So it's making you really acidic inside. So your pneumonia patients or patients with COPD or asthma they're going to have respiratory acidosis. There's going to be math, I'm sure. So remember the new thing we learned, 1 pound is 500 milliliters of fluid gained. 1 kilogram is the 1,000 milligrams fluid gained. And then we are supposed to get checked off on Tuesday on our IV spiking, priming, and drip rate. So we need to know this both for the exam and because we need to get checked off. So definitely go over your check off and make sure you have everything in order. Obviously doing your view gap, doing your 6 medication rates. Remember, we have to do 3 label checks when you pull it from the shelf, when you spike it and prime it, and then right before you attach it to the patient. You're going to check, the label for client's ID. You're going to make sure you have the correct solution and open it up. Inspect the bag for contaminants and clarity. Verify your drop factor on the tubing and also check your expiration dates on the tubing and solution. When you open the IV tubing, you're going to close your roller clamp. And then you're going to remove your plug from the IV bag and the stick protector, and you're going to spike your bag, and you're not going to touch either the spike or the IV bag opening. And then you would do your check. And then you're going to turn your bag upright and hang it. Then you're going to squeeze your drip chamber half full. And then you're going to open your clamp to let your fluid run through the tubing to get all those air bubbles out. You want to make sure that you verbalize that you're not having any air in the tubing. And then you're going to clamp it shut again. And you're going to apply clean gloves. And you're going to clean the connector on the patient with alcohol for 15 seconds. Then you're going to attach the IV. And then you're going to undo that clamp and regulate the IV per the order. And then just remember, obviously, you're removing your gloves and positioning of comfort, all that la-di-da stuff. Make sure you're washing hands, patient education, blah, blah, blah. And I'm assuming we're going to have to do a drip rate calculation for that. And hopefully manage to get it. If I forgot anything, I apologize. Or if you guys have still some questions, feel free to reach out and I'll try to help you through it. And I will send this along with the cheat sheets that I wrote out for you guys. So good luck studying, and we got this. We're gonna rock it out. We made it this far. I'll see you guys on Tuesday.